This is an overview of the Northwell Phelps Immersion in Clinical Empathy and Reflection Pilot, or NICER pilot study, undertaken by myself, Rebecca McAteer, with colleague Candace Johnson, one of our staff nurses here at the Northwell Phelps Hospital. I'm faculty with the Family Medicine Residency Program here in Sleepy Hollow, New York. We were interested in looking at this mainly because of the thought that, or the hypothesis that some degree of immersion in the patient illness experience by providers or by trainees learning to become providers in medicine would somehow translate into improved empathic delivery of care because of simulation of the lived experience of our patients. And so we looked into the literature, and I was very surprised actually to find that there was scant research done from the medical provider perspective, specifically physicians and specifically primary care physicians. There was a fair bit in the nursing literature. This seems to be part of many nursing training experiences, but there was a smattering of data from the emergency residency literature in terms of going through one's own emergency department to learn what that patient flow is like and that experience. But I wasn't able to really find anything published from primary care training settings. So we were interested in creating at a pilot level a feasible and scalable approach to implement such an immersion experience, simulating the illness narrative, as well as studying its effects, which we hypothesized again would improve empathic connection through immersion and self-reflection. So in terms of objectives, we wanted to invite voluntary participation in a simulated overnight hospital admission. We asked for completion of anonymous pre- and post-experience validated questionnaires and a brief narrative reflection, which I'll speak about in a moment. And then to analyze the participant data and post-pilot modifications, which is still forthcoming. The study has been completed, but the data is still pending. And so we're in the midst of collecting some of that. In terms of design, participants gave informed consent, and they were provided information about the study with a tracking card, which I've shown here in figure A. Under tools. We felt that would be useful for facilitating study-related scheduling, given that it was on a rolling timeline based on the participant availability as well as hospital census capacity on any given day. On the day of their scheduled overnight stay, the participant was registered through the hospital's admitting department. They were given a diagnosis of acute congestive heart failure due to viral myocarditis, although they were not notified of that. That was something that was part of a scripted protocol that would unfold over the 14-hour experience, during which they received usual care of a typical inpatient hospital stay, with the exception, of course, of any invasive procedures. So they did not have any blood draws, or no catheters were placed, of course. They did not even actually have the vital signs checked, although we did, based on the hospital floor protocol, simulate the obtaining of a blood pressure or a heart rate or a pulse oximeter, just to know what that's like at 4 in the morning to be awoken for your vital signs, that sort of thing. They were given a 2-gram sodium diet, for instance. Strict eyes and O's were monitored. They were put on a bed alarm bed with fall precautions. So there were some things that we were able to simulate, and that this was all done, of course, via IRB approval with the Northwell team. So at baseline, and again at 2 points, both 1 week and 6 months after completion of the overnight stay, subjects were asked to fill out the Interpersonal Reactivity Index, or IRI, which is shown here in figure B. It's a validated Likert scale questionnaire that measures empathy across 4 subscales. It's actually more than 30 questions, but I just put a portion of it there in the diagram. And we also asked for the subjects to complete a reflection survey that I developed internally with these questions. So following the experience, I expected, I was surprised by, I was thankful for, I was disturbed by, and finally, I think I will practice differently in the way that I. And so they were able to give a few words or a few phrases in response to each of those. All of this was done online. They did have the option of doing it on paper if that was easier for participants, although we encouraged them through the REDCap data monitoring and data collection database interface. So we encouraged participation through that. And so in terms of primary endpoints, we were interested in seeing how many people were able to complete the overnight experience, and then also all the accompanying questionnaire and survey tools. We look forward to analyzing the data when it's all fully compiled, as I said, once the 6-month, all of the 6-month follow-up data is in. Our target sample size was 10. We were not able to achieve that. We only got 7 participants because the study had to be curtailed due to the COVID pandemic. I'll speak about that shortly. And we also plan to assess the survey response, the reflective survey response, qualitatively, and look for some themes that emerged there. So in terms of outcomes, we aimed not only to explore additional facets of empathy training through the simulation exercise, but also to create a standardized approach. This was in some ways the most important piece of what we were doing, was to have something that could be scaled and shared as an evidence-based practice to help other programs if they were interested in simulating an immersion experience. What are some of the components, and what would that involve in terms of administrative support across the hospital team. As I said, due to the COVID-19 SARS pandemic, enrollment and participation was limited, and we had to curtail it in early 2020. So we really only were able to get around 7 people. We had 10 people registered, but only 7 were able to complete the survey. So we didn't achieve target numbers. But I do feel that we were able to create a feasible approach, and we look forward to studying it and utilizing it in the future. So in terms of next steps and future directions, the data are forthcoming regarding those subject surveys, as I mentioned. So we anticipate completion of all of those 6-month follow-up surveys by May of 2021. That's because we were able to get a few people in during a brief window when there was, between the first and second wave of COVID, we had approval to reinstitute, I think at that point, 2 of our outstanding participant experiences. But based on the developed protocol, we hope to incorporate this immersion experience into resident orientation activities that might start as early as July of 2021 with our incoming intern class. And then we also plan to seek IRB approval to conduct focus groups for qualitative analysis, exploring attitudes and outcomes of this NICER experience. I have some references listed there, and I look forward to hearing any questions or comments in the comment bar. Thank you.